want to go back to Monty. He did such a good job summarizing our frontline phase 3 studies that really got us into this frontline space. Monty, the second line space, it's a little bit older. These studies aren't quite as fresh, but they're still the best studies we have in the second line space, and they led to a lot of the approvals for these drugs and drug combinations now in this that we have in these patients with previously treated metastatic renal cell carcinoma. Can you walk us through sort of what data we have and what's kind of shaped the NCCN guidelines and other guidelines based on those studies?
So I can try. I'm still kind of scarred because you gave me an A minus, and I've never gotten an A minus in my life. So
I believe that, actually. I believe that.
I'm joking. But no, I'll dial it way back. I'll go back to record one, which was a study that compared. It was way back, right? Everolimus versus placebo, very modest benefit in terms of progression-free. And we go to Axis, which was a comparison of axitinib against sorafenib, not a placebo control. Modest gain, again, about 2 months in terms of progression-free survival, no overall survival advantage. And then came this slew of studies that I think reset the bar for second line, where you really had to have an OS advantage to demonstrate impact. So Checkmate 025 compared to nivolumab versus everolimus showed benefit in terms of response rate and overall survival. And then you had the trifecta with the Meteor trial with an improvement in progression-free survival, response rate, and overall survival, cabozantinib over everolimus. Another study that I think becomes important in the context of the current first-line discussions that we're having is lenvatinib with everolimus. So this was examined in the context of a randomized phase 2 trial, looking at len-ev versus lenvatinib monotherapy versus everolimus. In that comparison of lenvatinib everolimus against everolimus monotherapy, you see a very significant benefit in terms of progression-free survival, with, I would say, actually maybe a modest benefit in OS, although certainly not the statistic to demonstrate that, with only about 50 patients in treatment arm. So that's a quick rundown of the available second-line data sets that we have. Dan, am I missing anything there?
No, I think that's pretty good. Good. We won't ding on the Axis study. I think that's okay. So I think that's great, but all of those studies were done in an era where we weren't using frontline IO. And, or if there was some frontline IO, it was very, very small proportion of the patients. So now we've got, both frontline IO and frontline TKI. How do you interpret these now? How do you just sort of say, well, those same robust benefits and everything apply? Or are you now kind of rethinking we need a whole new set of phase 3 studies in this refractory setting to really guide us?
I'm leaning a lot on some of these retrospective data sets. I mean, they come with all the caveats of encompassing a very, highly selected patient population. A lot of these are really sort of limited to, robust academic medical centers. But, the signal that seems to be emerging is that there seems to be good, if not better, benefit in the second line setting with agents like cabozantinib, similar data for axitinib, leaning heavily on those to establish what I use second line. And to echo something that Niraj said earlier, I think that cabozantinib has sort of really become my preferred second line treatment if I haven't already used it front line for a patient.
Yeah, I think that's exactly right. And I think it's really interesting, the same logic holds true in the second line as the first line. We can't necessarily count on patients getting to third or fourth line. If you look at the number of patients that get to second line therapy but don't necessarily get beyond that, it's, at least when you look at some of these, larger outcome databases, it's about half. So it really suggests, again, choose wisely in this second line space. Raina, what are your thoughts on, the guidelines in the second line space? Where do you kind of use the guidelines to kind of help you? Are they helpful at all? Or do you have any thoughts on how you kind of tease out what to pick next in these patients?
Unfortunately, right now, I don't think the guidelines actually reflect what the guidelines for second line don't actually reflect how we're practicing for first line. Because all of these trials, as you stated, they were conducted in the VEGF era with VEGF TKI alone in the frontline space, which is not how we currently practice. So I think there's a critical unmet need there of sort of what is the best treatment option post IO, and what how do we select therapy in somebody who's received an IO combination, whether it be nivo-ipi or whether pembro-axi or gulimab-axi, nivo-cabo, what have you. Our front line is changing, and therefore our second line, not to say has to change, but we need to evolve the second line to match the front line. So, I think this segues into the CONTACT-3 study, which is currently ongoing, which is a critical trial of definitely, meeting an unmet need in several aspects. One, it is a trial that is a post-IO trial, and it's designed that way, post-checkpoint inhibition. And it's also a trial that includes non-clear cell. Largely everything that we've been talking about thus far has been, clear cell. All the trials were designed for patients with some clear cell components. So this trial includes patients with unclassified and also papillary histologies, which is a great unmet need. The trial is randomizing patients to cabozantinib, with atezolizumab versus cabozantinib alone. And so I think it's going to answer an important question of what's the role of IO post-IO, and what's the best strategy in the second line space post IO or IO VEGF strategy up front. But I do agree that cabozantinib is the best TKI that we have to treat kidney cancer. It combats that mechanism of resistance to VEGF inhibition, with its CMET activity, and I think it's really the best drug out there from a VEGF standpoint. And honestly, I think when cabozantinib first came around, we really didn't know how to use it well. Like the dosing was a little bit off, and I actually find that now it's probably one of the easiest TKIs to use. And whether somebody starts at 60 or 40 milligrams, 20 milligrams, it's actually a pretty easy TKI to use, and the side effect profile is predictable. So it is my go-to if somebody has not yet received it in the frontline space, but that may all change with the nivo-cabo data. We're going to have to wait and see what that data looks like when you use your best drugs up front. And I think piggybacking on that, Cosmic 313 is, again, looking at the triplicate of nivo-ipi-cabo versus nivo-ipi, and an important trial where the control arm now is an active IO combo regimen. So, I think the field is going to continue to evolve, over the next couple of years, but we need strategic trials looking at sequencing, what's the best sequence, and what do we do for the non-clear cells? Do we just mirror what we're doing for the clear cells? I think those are unmet needs, but I don't think the guidelines actually reflect right now what we're doing in frontline. I think they're a little outdated. We got to wait for the trials to read out.